Good afternoon, everyone. Thanks so much, Dimitris, for your nice introduction. I'm extremely pleased of being here today with all of you. It's my first visit to a country abroad since the beginning of the pandemics. And no, I'm very happy of having friends here that have very warmly received me. And thanks again, Theo, for organizing this. I'm very thankful. And in the next following minutes, I'll speak about this topic, the prone position in COVID-19 and beyond. These are my conflicts of interest. I think that maybe I can take up the mask.
And Jordi,
Yes.
I need to ask for a favor.
Huh?
You shorten your talk by 5 minutes,
All right.
whatever you have
Right.
organized.
Okay. So this is the topic that we are going to discuss in the next following minutes, and is the schema of my presentation. And let me begin with the rationale for prone positioning. And I like this study because it allows us to fully understand why prone positioning is useful, especially to decrease ventilator-induced lung injury. And here you can see in this slide, when you compare supine to a prone position, there is a significant decrease, these black areas, in the non-aerated zones. So this means that there is a huge decrease in in the areas that are collapsed. There is a significant decrease in the over-distended areas from supine to prone, and there is a slight decrease in the poorly aerated areas and a major gain in the well-ventilated areas. These altogether explain a much better ventilation to perfusion relationship, better oxygenation, decrease in shunt, and also the decrease in the overdistension, and possibly the decrease of diatelic trauma thanks to the decrease in these non-aerated areas. Altogether explain why this position has major advantages over the supine position in patients with IRDS. This is the modeling of the positioning, and if you look at the right hand side of the slide, when gravity exists, which is the normal conditions. Now, in this model, the authors assume that that the lung is a sort of cone, which is put in a cylinder, which is the thoracic cavity. And when these two geometrical models are one inside the other, you see that there is a major collapse in the dependent areas, whereas when you change the position, is a much better shape matching between these two structures, and this provides a more homogeneous distribution in the overall inflation. Now here in this part of the figure, you see the distribution of ventilation in supine, and you see that the majority of the ventilation is distributed in the non-dependent areas, retrosternal areas, whereas in supine position, the distribution of ventilation is much more homogeneous along the dorso-sternal axis. This is more recent data obtained in COVID-19 patients, and I would like that you focus to the right hand side of this cartoon, in which the authors compare part of the effects of different levels of PEEP, 8, 12, and 16. No, they also compare supine and prone at these fixed levels of PEEP of 12 centimeters of Wurth. And what you can see here is that when you turn the patients from supine to prone, there is a major decrease in shunt, which is this red column, the red part of the column, and there is a decrease in the dead space, so possibly because there is overdistension in the ventral part of the lung. Now, the dependent parts, the retrosternal parts in supine, which again, not possibly explains the long-term effects in terms of protection of the lung and avoiding over distension. What about the COVID-19? Well, this is the colossal magnitude of this single disease. And until today, we have more than 250 millions of people infected with this virus, and more than 5 million deaths. And indeed, this is a deadly disease, especially when patients are admitted in the ICU. The average mortality rate in mechanical ventilated patients is about 35%. No, this is data obtained in our region, in Catalonia, in the first wave of the pandemics. No, we live in an area of about 7 million inhabitants, and we collected data in about 80% of all the patients admitted in the ICU in this first month of the pandemics. And the vast majority of patients, a total of 1,700, the vast majority, 80%, needed intubation and mechanical ventilation, of whom 34% died. And the use of prone position in these patients that needed mechanical ventilation was above 70%. So it was a huge amount of patients being ventilated with prone positioning during this disease. And the same in this French study. This across many centers in France is, I think, as far as I know, is the largest series published up to date. More than 4,000 patients, and of whom 2,600, 63% were intubated and mechanically ventilated, 36% mortality. And of those patients having an IRDS, again, no similar data to ours, is 70% use of prone position in these subjects. This is an issue of interest. It has been a lot of controversy about the differences between traditional IRDS versus COVID-19 IRDS. I'm sure that you are aware of this. And this controversy started with this letter published in the American Journal, saying that in these patients, they had no higher compliance than expected as compared to traditional IRDS patients, and they had a high fraction of shunt. So this led the authors to make the hypothesis that COVID-19 was or had two different phenotypes. No, one that the authors called low for low elastin, so high compliance. And compliance is high because, as you see here, the lung is black, so it's empty of gas. And also low ventilation to perfusion relationships, explain the hypoxemia. Low weight, because are not collapsed and there is not much flooding, and low capability of recruitment. Whereas another phenotype, there is a so-called high or H, is high elastin, so low compliance, high intrapulmonary shunting, explaining the hypoxemia as well, high weight because the lung has totally collapsed and flooded with edema liquid, and high capability for recruitment. Okay, then when you go to data collected by others, these differences are not that clear-cut. It looks like compliance in this study in patients with COVID is slightly higher than compliance in patients with not traditional IRDS. Nevertheless, the alterations in gas exchange and the ability to recruit the lungs was almost identical for these two conditions. Still here, these data from Cumelo and co-workers, and here in the right-hand side of the slide, you see that for patients with the same compliance, patients with traditional IRDS, the blue dots, and patients with COVID IRDS, the yellow dots, for the same compliance. Okay, so in theory, the same amount of gas inside the lungs. Compliance is directly related to the amount of gas that is inside the lungs. Patients with COVID-19 are significantly more hypoxemic as compared to patients with traditional IRDS. So to me, this makes sense because, as you know, COVID-19 is an extremely vasculopathic disease. And it's conceivable that there are not only mechanisms of shunt and VQ alterations explaining hypoxemia, but also possibly a loss of hypoxic pulmonary vasoconstriction, etc. So it's I insist, it's quite conceivable that due to the special physiopathologic characteristics of this viral infection, giving a prominent vascular lesions, especially in the pulmonary bed. This explains the amount of the severe hypoxemia that these patients often have. Now, again, in these patients, and this is reproduces the data obtained in traditional IRDS when you prone early, within 48 hours of ICU admission, as compared to not prone early. No, there is a significant benefit in terms of mortality. So again, this indicates that when you have to prone patients, you have to do it as early as possible. And as a consequence of the pandemic and of the overwhelming amount of patients that have collapsed the hospitals, the emergency services, the ICUs, etc., clinicians, in order to provide a non-invasive way to improve gas exchange, they have tried the use of prone positioning. And this treatment has even been led by the media that Theo knows very well, how media can drive decisions in COVID-19. And here is the lady that survived because she was able to tolerate in a hospital in Chicago long hours in prone positioning, and finally she avoided intubation and mechanical ventilation. And this is the first study published by the group of Monza, by Coppo and co-workers, indicating that in a short, in a study conducted in a short number of individuals, very selected, that indeed the technique is feasible, and also it provides in the vast majority of patients a significant improvement in oxygenation. This is the largest trial published today. I'm not going to go into the details because I think that we are running out of time. But this is a trial interesting because of its design. It's a study that merged different randomized clinical trials in one big single one. And in total, they put using similar protocols, not identical, say similar. No, they merged a total of more than 1,000 patients. The primary endpoint of this study was a combined occurrence of intubation or death. And what the authors observed was that for the primary outcome, intubation or death, there is a significant benefit for the awake prone position. But the benefit was mainly driven only because with awake prone positioning, you significantly avoided intubation of the trachea. Nevertheless, all the patients, irrespective of being or not intubated when you take the whole population, the mortality is identical in the two groups. This is another strategy which I think is interesting and definitely much more comfortable than awake prone positioning. I think that awake prone positioning is difficult, at least in our experience, is difficult to maintain for long periods of time. Whereas this position, seated position, no, I think is no much well, much better tolerated by the patients. And again, in this small study, 25 patients, the authors showed the major physiological benefits in terms of benefit of gas exchange. Whether or not this translate to other patient-centered outcomes such as intubation, mortality, etc., we do not know. But I think that this is a position that you have to consider, provided that the patient not tolerates this seated position for for treating these patients. So we still recommend then prone positioning. This is the last no, guidelines published some years ago before the pandemics, and was for traditional IRDS. This is a more recent review that we published a few months ago, no, in the middle of the pandemic, indicating the same. This has been discussed before by Professor Evangelia Kumenaki. And in this study, again, what you see is that the best strategy, know that you can take nowadays to provide supportive treatment in patients with ARDS is the combination with low BT. And here low BT is defined as BT below 8 mLs per ideal body weight. And this combination low BT with prone position. Well, we did no an editorial that I skip because no, I'm going to finish with this slide. What do we recommend to treat these patients? So we treat them in prone position when the alteration in gas exchange is severe enough. We keep the saturation within these boundaries, 95%. We try to avoid FiO2 I think that you have to keep this in mind because rapidly induces denitrogenation atelectasis and can produce paradoxical hypoxemia. So better avoid no FiO2 apart of the likelihood of toxicity. No, pure oxygen is also highly toxic. No, this we use moderate respiratory rates to keep normal pH. No, 730, 735, a low BT. We use no volume control ventilation for a number of reasons. And we titrate PEEP according to a Mercat study published a number of years ago in JAMA, which is to increase PEEP to reaching a plateau pressure around 28 centimeters of water. Or now, more recently, we try to titrate PEEP according to the capability of recruit the lungs, and we do not too simple intratidal volume curves, and we determine whether or not these patients are able to be recruited. In obese and severe obese patients, we use esophageal balloons and we titrate with neutral or slightly positive transpulmonary pressure. We always keep the drivings below 15. We decrease instrumental dead space for obvious reasons. And we paralyze the patients when needed. And of course, we titrate individually according to the clinical status and evolution of the disease. So just to conclude, the prone position in COVID and non-COVID patients is feasible, is generally safe. You need to have some experience but is a technique that is not difficult to learn, is obviously non-expensive. And what is extremely important is that the prone position is a treatment. And as every other treatment, such as antibiotics in meningitis, for instance, you have to give it early. You have to give the appropriate doses. No, you have to use it for adequate periods of time. And of course, you have to done this very gently to avoid undesirable complications. I thank you very much for your attention.